we investigated the impact of remote patient management in a heart failure population. And in our heart population included patients with a recent heart failure hospitalization, no longer than 12 months prior randomization, and with no depression. And these key criteria were derived from the TIM-HF study in the subgroup analysis. More or less, the TIM-HF2 is a phase 3 study in telemedicine following the phase 2 study TIM-HF. The study was a randomized control, open, parallel, multi-center trial. The study was conducted in Germany, and we evaluated the remote patient management, and these conspire telemonitoring, pediatric education, and the cooperation from the telemedicine with the local caregivers. This is a holistic approach. And the technology we used was a multi-parameter non-invasive telemonitoring component. And moreover, in the telemedical center, we used algorithm. It's a form of early artificial intelligence to handle that. And it was very important also that this telemedical center was really a full department within a university cardiology and organized like a department, a division. And it was not a call center. That was a huge difference. Our facility service is always wondering because our workstation looks like a broker workstation, with many screens and so on. And they were one in the hospital, a little broker, but it is also only the integration of all information. The daily transfer of vital parameters from the patient with these non-invasive devices, and then the information from the local GPs and cardiologists, and then there's a picture. The most important point is that we have TIM-HF2 is a positive trial. We had the primary endpoint was percentage of days lost due to unplanned cardiovascular hospitalization or death of any cause, which is a composite and which is a patient-centric endpoint, because it's exact what the patient expects from good heart failure, to be alive and not in hospital. And the opposite is days lost. And the first secondary outcome was total mortality, cardiovascular mortality, and the other components of the composite. And we had a positive outcome in the primary endpoint and a significant difference in favor of RPM for total mortality. First, that the holistic approach of RPM management is able to reduce these endpoints I previously mentioned. Second, the key element is not the device at home. The key element is this holistic approach with the center of a telemedical center, which integrate all informations. And I think and this last point, is we can also achieve this effect independently where the patient lives. We had a subgroup analysis of rural versus metropolitan areas, and we saw no difference. That is, it could be an approach to overcome regional difference in heart failure care. Conclusion for the future. The heart failure care should be organized more or less in 3 parts instead of the outpatient clinic, inpatient clinic, and remote. In particular for the patient at risk after discharge for heart failure hospitalization. We are planning a TIM-HF3 trial in There are two challenges. The one is to upscale this. It was a 1,500 patient trial, which was huge. But the eligible patient for this approach are 100,000 in Germany. And that's why it is very, very difficult how to do that. And it requires much more technology and much more other processes to handle, to run out these for broader service. One, this is really something to do, not only to proliferate telemedical centers. And the second is about other indications or other target groups, and we think in the heart failure it would be the patient with LVADs, post-LVAD, but also other chronic diseases like COPD or other fields where this remote patient management would be useful or promising in terms of clinical endpoints, mortality, morbidity, quality of life.